So today's topic is how to optimize antimicrobials for a good antimicrobial stewardship, especially with the background of Metallo lactamase producing organisms. So as we know, this is a very common problem that we encounter in practice. So I'll just go to the magnitude of the problem. So what is the extent of this antimicrobial resistance? So this is if you project the number of deaths which are going to happen in 2015, this is an estimate. So it is believed that antimicrobial resistance would account for around 10 million deaths probably by the year 2050. This is when it is compared to cancer, which accounts for about 8.2 million deaths. Diabetes, of course, and its associated morbidities will account for around 1.5 million. Diarrheal diseases, measles, and all other things will account for about 1 to 1.3 millions of deaths. And road traffic accidents, as you know, again account for about 1.2 million deaths. So this is one of the major areas where medicine has to focus in the future. So the currently it is thought that around 700,000 people lose their life to antimicrobial resistance per year, and around 10 million are projected to die from 2015. So this is a major issue when you compare it to the other causes of major mortality. Now, India being one of the big population bases in the world, it carries one of the largest burden of drug-resistant pathogens worldwide. And 2 million deaths are projected to occur in India due to antimicrobial resistance by around 2050. So this is a sheer drain on uh, the economy as well as on the healthcare services. So there is a WHO global surveillance of the antimicrobial resistance reveals that antibiotic resistance is no longer a prediction for the future. It is happening right now across the world and is putting the ability to treat common infections in the community and the hospitals at a major loggerheads. Now, what is the current scenario with respect to the Indian scenario? So the WHO, in collaboration with the Department of Biotechnology, Government of India, has released the Indian priority pathogens in 2020. So the Indian critical priority pathogens are mainly Enterobacteriaceae and non-fermenting bacteria. As you all know, we experience this in our daily practice, especially in a immunocompromised setting or those patients who has undergone a transplant and who develop a very dangerous infection. So among the Enterobacteriaceae, the most common are Klebsiella pneumoniae and E. coli, and it can lead to the most common organisms that are the spectrum of resistance that are encountered are carbapenem resistance, digicycline resistance, and even colistin resistance. And among the non-fermenting bacteria, the bacteria include Acinetobacter baumannii and Pseudomonas aeruginosa. The Pseudomonas aeruginosa is always a trouble in the ICU as well as in any clinical scenario settings, especially in a diabetic. So again, the resistance patterns that are encountered are carbapenem resistance and colistin resistance. So so the E. coli resistance to carbapenem has to be estimated to around 42% are resistant to carbapenems in surveys conducted by the Department of Biotechnology. And resistance to Klebsiella pneumoniae to carbapenem, it is thought to be around close to 72% resistance. So there is a definitely an alarming level of carbapenem resistance among gram-negative pathogens like E. coli and Klebsiella pneumoniae in India. Now, the major pathogens are listed and what is a resistance pattern that is seen. So in E. coli, the major one are ESBL, extended spectrum beta lactamases resistance. Then Metallo beta lactamase resistance are there. Oxacelinase resistance is there. Klebsiella pneumonia, there is, of course, ESBL. And Metallo MBL resistance is also seen. And New Delhi variant of metalloproteinase, everything is often associated with the Klebsiella pneumonia. This is a very nasty strain and it can lead to very dangerous fulminating infections, and it is not amenable to treatment as well. And Acinetobacter baumannii, again, it can, there is carbapenem resistance. It is primarily an oxacelinase resistance. And Pseudomonas aeruginosa, this pathogen is important because it has a lot of inherent properties by which it confers resistance to itself, and it also transfers the resistance patterns to other microbial organisms. Again, the resistance pattern that is seen is mainly ESBL, Metallo beta lactamases, and co-production of ESBL and NDM. So this is a resistance pattern that is normally seen. So there is a rising carbapenem resistance among E. coli, Klebsiella, Acinetobacter baumannii, and sometimes carbapenem resistance rates can even touch 87% in some series. So oxacillinase and NDM production, co-production is most commonly seen, especially in Enterobacteriaceae. So before going to the subject proper, we'll see how the microbial organisms evade the antibiotics. So the first and foremost is by increasing the drug efflux. So the drug gains entry into the organism, but the pathogen makes certain efflux pumps, which will effectively pump the medicine out of the antimicrobial cell from the microbial organism. So this is one mechanism. This is somewhat similar to the defense mechanism employed by cancer cells. And the second one is a decreased uptake of the drug. This is particularly seen in Pseudomonas, where they have porins in their outer membrane, and these porins are not permeable to most of the antimicrobials. So this is one mechanism by which it confers resistance on the antimicrobial agent. And the third mechanism is by drug modification or destruction. That is by producing beta lactamases, and the beta lactamases which will hydrolyze the beta lactam ring of the beta lactam antimicrobials. And the last one is by target modification. So the microbial organism changes the target of the antimicrobial drug. This is typically seen with certain, again seen with Pseudomonas, where they change the peptidoglycan bond so that the antimicrobial agent or the beta lactam molecule will not get an attachment onto the peptidoglycan chain. So this is another mechanism. So these are in general, the four mechanisms which will confirm antimicrobial resistance. Now coming to the beta lactamases, this is a bit of a complicated thing. And how do you classify this? There are lots of classification, and this is one of the earliest modality of classification. So classification is known as an Ambler, or is known as a molecular classification. So you have to understand initially there were only two classes. There was a class 1 and a class B. So the class 1 was serine beta lactamases, and the class B was Metallo beta lactamases. Now the Metallo beta lactamases are so named because they normally require the addition of zinc also to confirm the beta lactamase property. So zinc is a very important molecule which confers the beta lactamase property to the Metallo beta lactamases. Now, with the advent of other genetic methods as well as molecular biology, so two more classes of serine beta lactamases have been identified. This is a class C. The prototype was AMC. Now, the class D molecule is also, again, these all contain serine beta lactamases. The class D contains oxacillinases. A lot of oxacillinases are there. And in the Metallo beta lactamases, here the NDM. NDM is a New Delhi Metallo beta lactamases, first identified in the New Delhi strain. So these are the Metallo beta lactamases. This is one way of classifying this beta lactamases. Now, the second way of classification is depending upon the molecule itself. Like you can have penicillinases or beta lactamases, broad spectrum beta lactamases, then extended spectrum beta lactamases, and carbapenemases. So a lot of other classification modalities are there, but this is a classification which is traditionally done to classify the beta lactamases. Now, you have to understand there is a 30% rule. So 30% of all hospitalized patients are given antibiotics at any point of time. And around 30% of the antibiotics are prescribed inappropriately in the community. And about 30% of all surgical prophylaxis is inappropriate. 30% of the hospital pharmacy costs are generally due to antimicrobial use, and around 10 to 30% of pharmacy costs can be saved by good antimicrobial stewardship programs. So the infections in India, we have a very huge burden of infectious disease when compared to the West, because we have an abundance of infections like malaria, tuberculosis, HIV, then vector-borne diseases, influenza, and other outbreaks, which commonly happens with the seasonal changes in the weather or the standard of living or the personal hygiene. Then, of course, you have diarrhea and pneumonia. Then, of course, there is a risk of hospital-acquired infections if the current, if the standards of care are not well practiced, like hand washing and other things. Then sanitation conditions, poor infection control practices, and malnutrition. Again, we have a close animal-human interface, which will increase the risk of infections in our country. Now, the antimicrobial resistance has emerged as a major public health problem all over the world. And infection caused by resistant microbes fail to respond to treatment because of limited therapeutic options. So the failure of treatment can lead to prolonged illness and morbidity and mortality, greater risk of deaths, longer periods of infectivity, and increased number of infected people in the community, which is a self-perpetuating cycle. So the resistance equation, it all depends upon the antibiotic pressure. So changing antibiotics now and then, and use of broad spectrum antibiotics inappropriately is again one thing. Then genetic selection also matters. Then risk of cross infection can happen. So this is a cause for the emergence of resistance and hospital cross infections. And about 50% of antimicrobial use has been found to be inappropriate. So the strategies should be there to prevent the emergence and spread of healthcare associated antimicrobial resistance organisms are essential. So the correct effective strategy will require an effective clinical antimicrobial stewardship program, meticulous hand hygiene, surveillance and monitoring of antimicrobial resistance, especially MDR organisms. Now, what is antimicrobial resistance profile of major pathogens? So, if we look at the gram-negative organisms, you can have carbapenem-resistant Klebsiella. Again, around 59% is seen in India, this carbapenem-resistant Klebsiella pneumonia. Fluoroquinolone-resistant E. coli around 84%, and carbapenem-resistant Acinetobacter baumannii, described in various series, is up to 77%. And if it is a gram-positive organism, oxacillin resistance of Staph aureus is a major problem. Then aminoglycosides and even vancomycin resistance enterococcus is another problem seen in about 60% of the microorganisms. So from a clinical point as well as from a clinical scenario, so the Enterobacteriaceae is one of the most important group, which leads to severe hospital-acquired infections as well as very troublesome infections leading to multi-drug resistant infections in the hospital in the hospital patients. So again, the resistance pattern could be due to, as I already told, it can be an efflux pump. It can be due to inaccessible porins, which will block the entry of beta-lactam antibiotics. Then beta-lactamases, which are produced by the plasmid transfer or by the inherent genetic mutation which happens in the bacterial chromosome, that will lead to beta-lactamases, and it will lead to inactivation of the beta-lactam antibiotics. So the carbapenem-resistant Enterobacteriaceae management primarily depends upon better infection management and prevention. Rational use of antibiotics should be there. So how do you tackle a multi-drug resistant infection? So what is the antimicrobial effective against a gram-negative infection, given such a burden of beta-lactamase resistance and carbapenemase resistance? Sorry. So one answer to this is a molecule which is known as ceftriaxone sulbactam, which is combined with an EDTA. So ceftriaxone sulbactam EDTA, as you all know, ceftriaxone is a cephalosporin. So this is a third generation cephalosporin, which is combined with sulbactam. Sulbactam is a beta-lactam inhibitor, and the EDTA is also there. So how does this EDTA is now termed as a antibiotic resistance breaker. So this antibiotic resistance breaker, it acts as an antibiotic resistance breaker mainly by chelating zinc ions in the Metallo beta lactamases. As I already told you, this Metallo beta lactamases require zinc for their activity. So zinc is a major ion which is needed for the activity of the metallo beta lactamases, and EDT acts as a resistance breaker by chelating the zinc. So the metallo beta lactamases are rendered ineffective. Then another mechanism is it reduces expression of the efflux pumps, and it increases the permeability by chelating magnesium ions. As I already told you, the porins are there in the outer membrane, especially in gram-negative bacteria, like for example Pseudomonas, and magnesium is needed for the porin activity. That it blocks the entry of the antimicrobial. So by chelating the magnesium ion, it increases the permeability of the antibiotic by the porin. Then the another mechanism is by disrupting the biofilm formation. And the last one is by decreasing or inhibiting the horizontal transfer of resistance by the plasmids. So why this ADTA? You are using sulbactam. The sulbactam mainly binds to the serine proteases. So it inactivates mainly the serine proteases. As I already told you, this beta lactamases, a major classification is by serine proteases as well as metallo beta lactamases. Now this EDTA is the most important chemical which is involved in the inactivation of the metallo beta lactamases. That is a type B beta lactamase by chelating the zinc ions. So these are the main mechanism of action by which it acts as an antibiotic resistance breaker. So this terminology is important. It is known as a resistance breaker. Now, are there any evidence or any studies which have shown the efficacy of this antibiotic resistance breaker? So this is one study. It's an International Health Management Associate study. And this is a global organization with labs in Europe and US. And it has experience and expertise in vitro antibiotic susceptibility testing, global surveillance program, and antibiotic development. So this is a study which is done and is just presented at the 2023 European Congress of Clinical Microbiology and Infectious Diseases. So the main objective of the study was to evaluate the in vitro activity of ceftriaxone sulbactam EDTA combination against carbapenem not susceptible enterobacteria and non-fermenter isolates. And this study was conducted from India and South Africa for a 5-year period from 2016 to 2021. So they used this drug in carbapenem resistant organisms primarily. So around 866 enterobacteria and non-fermented clinical isolates were isolated from India and South Africa. And the majority were enterobacterials and non-fermenters. And the isolates were from varied sources of infection, including blood, gastrointestinal, respiratory, genitourinary, and peritoneal fluids, with the respiratory source and the gastrointestinal, and the blood being the most prevalent source. And the susceptibility testing for ceftriaxone sulbactam EDTA was performed by a broth dilution technique. And a subset of isolate from India, mostly meropenem not susceptible, that is a meropenem resistant, was screened for the presence of beta lactamase genes by multiplex PCR assays. Now, this is a minimum inhibitory concentration for all the organisms like amikacin, ceftriaxone, then meropenem, and EDTA molecule, ceftriaxone sulbactam EDTA. And against all the grouped organisms from the meropenem resistant isolates, the minimum inhibitory concentration was the lowest for our EDTA molecule, whereas meropenem one was more than 32 milligram per liter. So the minimum inhibitory concentration was very low with regards to ceftriaxone sulbactam and EDTA. Again, this is E. coli, the minimum inhibitory concentration for E. coli and Klebsiella pneumonia. And for against all E. coli isolates from India, the EDTA molecule, the minimum inhibitory concentration was 1 milligram with improved activity against meropenem resistant isolates. And for this NDM, New Delhi metalloproteinase producing Klebsiella pneumonia, the MIC was around 4 milligram per liter. So good molecule with regards to all these beta lactamases. Now, with regards to Acinetobacter baumannii and Pseudomonas aeruginosa, then oxacelinase producing strains, the minimum inhibitory concentration was even less than 0.03 milligram per liter. So the activity of this molecule was found to be more pronounced against non-fermenters Acinetobacter, and Pseudomonas aeruginosa from India. So the conclusion of the study was a combination agents like ceftriaxone, sulbactam, and EDTA displays potent activity against non-fermenters and carbapenem-resistant enterobacterials, especially NDM producing isolates from India. Now, this is another study which looked at specifically at the urinary tract infection, including acute pyelonephritis. It is a randomized, double-blind, randomized non-inferiority trial done by multiple centers from predominantly from the northern India. So it was a phase 3 prospective randomized multi-center double-blind study, and around 17 tertiary care hospitals and 230 randomized patients were included in the study. So the infections that were included in the study were catheter-associated urinary tract infection, acute pyelonephritis produced by gram-negative ESBL, and they are randomized into either Eloris. Eloris is our molecule, ceftriaxone, sulbactam, EDTA, 1.5 gram 12th hourly infusion over 30 minutes, and placebo at 8 hours and 16 hours. And meropenem was given at 1 gram 8th hourly. So they received treatment up to 14 days. End of treatment was around, at the end of the treatment, depending upon the clinical signs, were around day 5 to day 40. So what was a response rate? So the response rate varied between the Americans as well as the European standards. So the US Food and Drug Administration defined endpoints were symptomatic resolution at test of cure. So you should have a symptomatic resolution with a test of cure, and a symptomatic resolution as well as microbiological eradication. So they compared between these two, and in the European guidelines, the endpoint was a microbiological eradication at test of cure. So the conclusion of the study was the ceftriaxone sulbactam EDTA met the primary objectives of showing non-inferiority against meropenem in the treatment of patients with catheter-associated urinary tract infection and including acute pyelonephritis. So the susceptibility, they concluded that the susceptibility profile of the pathogens associated in the study highlights the increasing antibiotic resistance trends, and it warrants a need for new effective antimicrobials. So it is the ceftriaxone sulbactam EDTA can be supported as a potential alternative to carbapenem in the treatment of patients with all these life-threatening urinary tract infection, including infections caused by ESBL producing gram-negative bacteria. So this is with regards to urinary tract infection, and with regards to pneumonia and bloodstream infections. So again, there were studies. So this was a retrospective data analysis. So a retrospective study was initiated with the aim to analyze the comparative efficacy of this new molecule, that is a combination of ceftriaxone, sulbactam, disodium edetate, and meropenem in combination with colistin for the management of MDR nosocomial gram-negative bacterial infections. So there were two groups. So one group was meropenem with the colistin group. So this was our EDTA molecule along with colistin. Second was meropenem with colistin, and there was for some infections which didn't respond, they were shifted to this EDTA with the colistin. So the overall clinical success was slightly better with the EDTA colistin group when compared to this meropenem colistin group. So the EDTA colistin therapy resulted in significantly higher efficacy as compared to the meropenem colistin. So they followed out on follow-up. It was found that there was a rising trend in clinical cure rate with respect to EDTA use based combination therapy, in contrast to the decreasing trends in meropenem based combination therapy, and a progressive decline in clinical cure rates were observed in meropenem treated group over a period of 3 years. So this was the conclusion was the EDTA, the ceftriaxone sulbactam EDTA along with colistin therapy has shown better bacteriological and clinical efficacy as compared to meropenem with colistin in the management of various nosocomial MDR gram-negative infections. So what are the key points? So this particular molecule targets multiple resistance mechanism, and EDTA is an antibiotic resistance breaker. When added to ceftriaxone sulbactam, makes it more susceptible against gram-negative pathogens by combating multiple resistance mechanisms. So it is indicated in ventilator-associated pneumonia, bloodstream infections, and complicated UTI. And ADTA aids in better penetration of drugs, increased periplasmic concentration, and hence enhanced activity. And degradation of the biofilm, inhibiting the transfer of plasmids by conjugation and inhibiting the efflux pumps, and it causes increased periplasmic concentration, which is needed for antimicrobial activity. So, and MDR multi-drug resistance is a major problem for the treatment of bacterial infections and is becoming the greatest challenge to public health worldwide. And compared to infections due to antimicrobial susceptible gram-negative bacilli, infection due to MDR gram-negative bacilli leads to worse outcomes, including longer hospital stays, increased mortality, and greater cost of hospitalization. And novel treatment options have become available in recent years, providing some much awaited resources of effectively counteracting some severe MDR gram